Okay, first, I want to invite you to a cadaver course in July with Jaime Bertelli. He will show you his preferred techniques for nerve reconstruction in the upper limb, nerve and tendon transfers, and I will give in a third day I will show my flaps for the upper periosteal flaps for the upper limb. So the definition of non-union is non-union after 12 weeks. The risk of non-union is about 13% when the gap is more than 3-4 millimeters. That's just data, but I think it's interesting. And the main thing is that the extensor supinator mass tractions from the lateral condyle. So this is a mechanical problem. So what you need is stability. That's the way to manage it. So what happens is that because of that motion, the lateral fragment tends to migrate proximally, and and there is a progressive valgus deformity. And over time, you can get a deformity like this, severe like this. But it doesn't happen all the time. 30% of the patients get cubitus valgus, 50% have pain, and ulnar neuropathy about 50% also. And I will show you two interesting cases of a spontaneous resolution. So Ariadne had this non-union at 8 months. I scheduled, for some reasons, the surgery was scheduled 6 months later. And when we got to the OR, it was healed. But this is not just one case. A similar case, 7 months, non-union. It was scheduled by a friend, by a colleague, like 10 months after, but the child didn't have surgery, so came to my outpatient clinic, and it was healed. It was healed in, of course, malunited. But we are always worried about the malunion of the lateral condyle. But we can see that lateral condyle allows really a lot of degrees of malunion, and still you get very good motion of the elbow. So a spontaneous resolution occurs. I don't know if you have seen that. Okay, so this is one case. 8 months after of evolution, and what I did was a percutaneous fixation with a screw, and I got union in 2 months. And a similar case, 5 years old, 8 months of evolution, percutaneous screw. You see that there is not really compression, but just putting the screw provides some stability and allows the non-union to heal. So this is a third case. So here you can see that the lateral fragment is really unstable. In the other cases, it was not that unstable. So in this case, we put also a screw, really against the all fixation principles, and non-union. So it's still very unstable in union. So we put a second screw, non-union. Although motion was good. So there are failures with this technique. So this is the first long paper on percutaneous screw fixation. It seems that success is related to the time after fracture. And in this paper, the 4 failures were in older than 8 months evolution cases. A similar case, but almost all of them with percutaneous fixation succeed, and even cases with 18 months of evolution. So maybe in longer evolution cases, we shouldn't do, or we should not do this percutaneous technique for longer evolution cases, or maybe for those that are very unstable, as you saw in the video. So for those older cases, we should do open fixation, and the dilemma is if we accept the malunion, and we have to accept the malunion because if we reduce the fragment, the rate of osteonecrosis and the stiffness is high. So we don't reduce the fragment, we fixate the fragment in situ, and we can put at the outer place, we can put some grafting or not. This is so we are accepting malunion. I'm showing you another case of severe malunion of lateral condyle, really angulated in the frontal plane, and motion is good. Motion is good. Maybe this is the main paper or on open situ fixation. Like this case, 12 months after fracture, some bone grafting in the outer part, fixation, and you get a good result. And the result for this open in situ fixation are really, really good, with a low rate of osteonecrosis or stiffness. In many cases, you have a cubitus valgus. So in this case, you can do in 1 stage or 2-stage correction, but I prefer the technique that Scott Cousin prefers, is the TN technique, where in the same surgery you do a domosteotomy and a fixation of the lateral condyle. It would be indicated when the valgus is more than 20 degrees, maybe. And of course, if you have ulnar symptoms, an additional surgery would be the ulnar nerve transposition. Okay, but so we have provided mechanics, but we can also provide biology. And I came with this flap a few years ago. So using the posterior collateral radial vessels, you can take a flap from the lateral distal humerus. You have many branches, and this is the flap that you suture over a little bit debrided non-union. And look, it was previously operated with percutaneous fixation. It didn't work, so I did the flap, and you can see the callus at 3 weeks, 6 weeks, and later. So you see how without improving the mechanical conditions, just the biological addition is able to solve the problem. So biology defeats mechanics. What's the main problem for me to treat these non-unions with flap is cosmetics. The lateral arm incision. This is but it works perfect, and it's a tool that you can use. And this is a case of a multi-operated lateral condyle non-union not with valgus but with varus. And so I did through a posterior approach domosteotomy, and then I added this is the osteotomy, and I did the periosteal flap. And you can see at 4 weeks after removing the wires, No, I didn't use a screw for the non-union. You can see how it heals really, really fast and nicely. And this is the patient before surgery, and this is the patient after surgery. You can use this periosteal flap in adults. This is a case from a friend. This is a myeloma, metastatic, persistent non-union. And so this flap helped this patient and a similar patient, in adult, non-union of the proximal humerus fracture. He take the periosteum with the skin, and it worked properly. Again, inviting you in July to this cadaver course. So maybe a management strategy would be a non-union less than a year. Try percutaneous fixation. After a year, do open fixation or a periosteal flap, and it has a severe valgus. Do the TN technique with dome osteotomy, but always in situ fixation. Thank you.
You are silenced, Hisham.
Nice presentation. Thank you, Soldado. There is a question for you. How and when are you deciding whether to fix the non-union or leave it if the majority of elbow motion carrying through the non-union?
Yes, in very late severe cases, motion comes from the non-union, like that severe case I show you. In that case, don't treat the patient. This is a very good question. We rely in the new joint.
Yes. In these cases, sometimes they have severe cubitus valgus. Do you do osteotomy and leave the non-union as it is?
So I do the dome osteotomy, and I put the periosteal flap. But if I don't put the periosteal flap, I put a screw. So in the case I show, I use 2 K wires. That's all for the dome osteotomy, and I didn't fix the non-union because I relied on the periosteal flap.
But if the motion coming from the non-union side, then you want to leave the motion as it is from the non-union side. So you do osteotomy only without the need for periosteal flap or the need for fixation.
Right.
Okay. Any questions? I want to ask you about the timing for surgery. If you have or encountered the non-union, and I encounter sometimes patients with non-union, very mild deformity, full range of motion, they don't feel they have a problem. I don't like to operate on a patient who does not feel that he have a problem. So what is the cutoff point for you to operate on non-union if you can achieve fusion and good union for this fracture?
Yes, this is a really nice point. And the other thing is that, as you saw, some of them saw spontaneously. So I think that you can just follow the patient. If there is some progression, you treat the patient. Otherwise, you can wait. And the other thing is that more than half of the patients are not symptomatic. So I agree with you that if you follow the patient and there is no progression of the deformity, you can leave it like that, I think.
There is a
But
question.
this is not what literature says. For in the literature, you indicate surgery.
Yes. How do you decide through where motion coming from? I mean, if the motion is coming from the joint itself or from the non-unit side?
With the fluoroscopy, but in the but you can have a first sense in the outpatient clinic. Sometimes it's clear that motion is coming from the non-union. So, but if you have a doubt in the OR or under anesthesia or a fluoroscopy without anesthesia, I don't know. But don't fix that new joint, otherwise you will I cannot imagine fixing it and trying to do arthrolysis. I don't think is the proper thing to do.
Okay. No further questions. Thank you, Soldado, very much for this nice presentation.